It's a real honor to be here. I was thinking, what was I going to say? And listen to Jim speak, and I think the thing that resonated with me was passion. You find your passion. I came to this meeting when it was in its first inception in the early 2000s, actually, with the goal of being a virology researcher, looking at how enteroviruses get into cells. And realized at a crossroads in 2006, it actually would have been January of 2006, as I was looking at counting infected cells, that I needed maybe a different change, a different path, maybe family-wise, and needed to go somewhere else. And I always had thought stewardship was interesting. I always thought it was great that in Philadelphia I learned how to do or talked with people about antibiotic use. And I look at Susan Coffin, who had taught me these things, and being on stage with her and knowing that she'll be your next is always refreshing, thinking about those things. And so I headed off to Kansas City in 2006 to do antibiotic stewardship. And I would say that, your paths lead you to these places for whatever reason, but I was in the right place, right time. 2007, the antibiotic stewardship guideline came out from the IDSA. And it became clear, and as I was thinking, that this was me. This is what I needed to do. This is what I loved. And why was that? Well, a lot of reasons. One, you think about the history of antibiotic use, and I just keep thinking about 1933, a 10-month-old gets Staph aureus bacteremia. 1933, they were able to give them a sulfa drug, a sulfa-based drug that was born out of really studies into medicinal dyes, red dyes actually, Prontosil rubrum. And that child lived. Right? We don't even think about a 10-month-old dying of Staph aureus bacteremia. We also don't think about a child dying of a resistant Streptococcus pneumoniae. But now we all sit there and think about it, and we know that that's right around the corner. It could be easily seen by any of us in our lifetime now. And my dad's a physician. I grew up in a physician home as well. And I don't think in 1985, when he was taking care of a child and probably giving him azithromycin, much to my chagrin, he would think about that either, that we would see that. And in 2010, my own, at the time, 6-year-old daughter developed orbital cellulitis. And what would it have been like if it was 1900? What would it be like if it was 2050? So that, those, you step back and think about that, and you think about your own loved ones, and we all have our own loved ones, that this field of antibiotic resistance and managing our antimicrobial use better is key, is huge. And if you look at that historical perspective of how we came about to use antibiotics, so we get sulfa, we get penicillins, it revolutionized medicine. And then we allowed them to go. We allowed everyone to use them, and it became clear that it was us as physicians who would say, hey, these things work, we know they work. But there were no studies. There was no studies. There was no true efficacy studies early on. And as a matter of fact, there's an interesting book around this whole thing that even the FDA, we all took part into allowing that because we trusted our doctors. And now we obviously learned that it's changed. And so I think that became the passion, right, for me. That's what's driven me to continue to work on this. And then you think about other aspects, the agriculture industry and others. And so it's bigger. It's a lot bigger than I realized when I first started this in 2007. Now, so that would be the driver of what I think what could happen without this. And this is a more complex, as you think about antibiotic resistance and the use of antimicrobials than just overuse. It also includes that we still have to develop antimicrobials. We're going to continue to need these drugs. They're very important. So the field of antibiotic stewardship isn't just about saying no. And I think that's what a lot of people say, right? I mean, they see you walking in as the antibiotic steward and they're like, oh, you're just going to tell me no. Yeah, well, there's a lot. Maybe that's because a lot of times I need to, or we need to. And the reality of it is that no, we're here. We really are after using them right. It's not about no, it's about using them appropriately. And right now, we're just in such the infancy of antibiotic stewardship. I'd say infancy toddlerhood, right? I mean, if we think about it, Stan Plotkin and those in the early 1980s, Paul Offit told me, he says, we used to write a note on every patient that was on an antibiotic. That was the initial form of stewardship, at least at the Children's Hospital of Philadelphia. It was thought of, and people will say, yeah, we used to do things and not let people just use them. But then it just became we could use them all the time. And the reality was because we thought, we had a lot of use, and therefore, if we just decrease it, we must be better because, right, 50% of our use was inappropriate. Well, we're getting beyond that. right? Because people really care about this. And there's more work being dedicated to this. And as a matter of fact, I think you shared today earlier regarding the new appropriations that was, I think, $360 million or so many million in the recent omnibus from the government dedicated just to antibiotic resistance, which had this huge thing around stewardship and studying resistance more, which is great. I mean, which is getting us to the areas that we need to be. But we still don't have the metrics that are needed to say, hey, are we using our antibiotics right? We don't have the data that says how long should we treat a patient admitted to the hospital with community-acquired pneumonia and how long that treatment should be. We don't know that. We all would say, and our guideline says 10 days. And it has the caveat, it could be shorter, but we don't have the evidence. Which seems mind-boggling, right? It's been over 70 years since we started using penicillin for this condition. And that's the tip of what we have left to do, I think, with antibiotic stewardship. So I would say, what are the pros of this field? Oh my gosh, it's vast. There are so many things for us to learn. One is, if we have our antimicrobial stewardship programs in our acute care facilities, what are those metrics to say that stewardship program is performing the best way it should? We are in an era of where, the financial aspects of our care matter. So how do you sell the fact that these programs make a difference? Yes, we will walk in the door and you'll see antibiotic use go down. Therefore, your costs will go down. But is that the true value of the program? My wife, just to give you a little background more about me, is an infectious disease pharmacist who started her own stewardship program in a community hospital. She'll tell you stories about finding patients being sent home with Staph aureus bacteremia on azithromycin. Value, right? I mean, that's the piece. But we don't have the good studies. We don't know those true values. And we always say this around resistance, but we don't really talk about the adverse drug effects of these medications, which would go into the outpatient world, right? In pediatrics, we know that our C. difficile is greater in that setting for the most part. And how do you do stewardship in the outpatient setting? How do you get to that part of change? And so I would say one of the huge pros is that this is a social dynamic field. And so getting to work with some sociologists has been really intriguing and is actually the way to go when we talk about a lot of this, is understanding and learning the theories beyond just the quantitative science that we all learn, but really to get into the qualitative aspects. And that's where stewardship's going, and antimicrobial utilization is going, is trying to understand really behavior and human behavior. And I think the last piece really for me is really learning the best way of implementation. We don't really know that in many respects. All of our places are unique. If we would go to Stanford, if we go here to St. Jude's, if I go back to Philadelphia, now my journey has gone to somewhere new, right? I actually just started at Washington University in January. A whole new set of people, a whole new set of challenges of how do we talk about antibiotic use. And as we know, in the transplant community and some of the high-risk patients, they love their patients so much that sometimes it's hard to have someone come and talk about that. I really don't think you need that. Yeah, but they're really sick. And that, right? That to me is the beauty of this field. I mean, that's what's fun for me. It's challenging. You get called the police. You get called names at times for those things. That's okay. At least they tell them to my face. I'd rather be it that way. And so I think that I would say that pediatric infectious disease was by far and away the best decision of my life. I've got to do basic science. I've been able to go do antimicrobial stewardship, and in that path do patient safety, evidence-based medicine. And in all of that, I don't think it would have been possible in any other field. And I think I am excited. I can't wait to do more of the stewardship world and seeing what happens, because I think we are really going to see a lot of changes both nationally, internationally, as we all look at what antibiotic resistance is going to do in changing our clinical medicine. Thanks.